Good afternoon and good evening, everybody. Thank you so much for joining the American Society of Pain and Neuroscience and our March Madness debates. We are very excited for a super fun and interactive debate evening. So thank you for joining us. The debates themselves will start in exactly 2 minutes. In the meantime, we are rolling out a polling option during the debates this evening. So if anyone, while you're logging on, would like to practice polling, we have some fun polls to launch while we're waiting for the official program to start. So Lakin, would you like to run the first poll? And for those of you who are on, go ahead and answer the question.
It was a close one. Very tight.
Looks like Dawood wrote that question, I think.
This was like the presidential election in Georgia. Pretty close.
All right, last one.
Wonderful. Thank you, everyone, for participating in that first poll. That gives you an idea of what we will be doing tonight. So we are exactly 2 minutes past the hour. We have a huge amount of people on tonight, and I am turning the launch of the debates over to our two moderators, Dr. Timothy Deere and Dr. Dawood Saeed. Take it away, guys.
Well, welcome everybody. It's great to have everyone join us again this evening for another one in the series of the debates that we launched back at the end of 2020. And there's been such great interest and quench from, our members of ASPN for more of this. So we've continued to kind of progress with this. I know folks are probably really getting very eager to get back to in-person meetings, but I think this debate format has been a nice break from a lot of the lectures and stuff that we've kind of tuned into during the course of the pandemic. Tim, good evening.
Good evening, Dawood, and good to see everyone again. We have close to 1,000 people registered. I think we'll have someone live tonight, some on our website over the next week or so watching these debates. You'll get to vote, though, if you're here live tonight. July 22nd through the 25th, we'll be at Lowe's Hotel in Miami Beach live for our annual meeting. I think it'll be the first really energetic meeting of the year and for a long time. So I invite you to mark it on your calendars. A lot of the same folks you'll see tonight will be there at that meeting as well, and we can have a chance to interact in person. Tonight, really a friendly, collegial debate between good friends, taking different sides of an issue. And so I think this is the way many of us like to learn. This is how I like to learn. And you'll see Dawood and I coming in and asking questions to get a little deeper, and then you'll vote on each of the debates. And so this is, we coordinate this with the Final Four. Secondly, we are scheduling a very similar format in May with what we call our Young Guns. We'll have several young future leaders in the field, maybe up to 30 people on debating each other over an hour and a half. So we'll give you some dates for that very shortly. So Dawood, you want to talk about the sponsors?
Yeah, absolutely. Again, these events do take resources, time, and money, and it would not be possible without our generous sponsors. So we appreciate all of them that you saw on that previous slide, stepping up to the plate and making sure that we can continue to educate folks during this time. So with that, we'll kick into our first debate around the debate about how many epidurals should you move to or should a patient get prior to the mild procedure in patients with spinal stenosis. This will pit Dr. Jason Pope versus the very formidable Jackie Wiseman.
Thanks for that, Dawood. Jason, I think you're first, so when you turn your camera on.
Yeah, I'm working on it. There we are. I was thinking, I was caught in thought. I approach this the way that I try to approach most things in medicine, which is an evidence-based strategy looking at common sense application. And so the real question becomes, how long do you give an epidural to work in order to say that it's not working in the management and treatment of spinal stenosis? And there is, thankfully, a randomized prospective study looking at spinal stenosis treatment with local anesthetic alone or local anesthetic plus steroid in treating spinal stenosis. And what is interesting about this paper is that it essentially was done in a way where patients had an opportunity to cross over, either getting local anesthetic alone or steroid at a 6-week crossover. And essentially what it said was that at 6 weeks, if someone got relief with an epidural, it's very likely that they would have that enduring relief profile out to 12 months. If they did not get relief after 1 or 2 injections between a 0 to 6 week application, then they likely will not get benefit from an epidural, and they would have to move on to other interventions, including decompressive surgery. So when we look at how many epidurals, when you look at this paper, people had access to anywhere between 1 and 3 epidurals within a 6-week period. If they got enduring relief at that 6-week period, then that relief was maintained at 12 months. If they didn't get that period at 6 weeks, then you need to move on to do something else. So I guess when we're talking about a debate, I would say follow the data. So this was a study that was published in 2017. I was turned on to it by a good friend and colleague, Dr. Fishman. And I think that it has helped shape my practice and my physician partner's practice and how we apply epidural steroid injections treating spinal stenosis prior to mild. We have data on the mild, right? So comparing mild to epidural injection, it appears that mild was superior in an enduring relief profile. So as Tim's coming on, I will conclude my remarks. Thank you.
You had 30 more seconds, Jason, but I think that was really a good argument. Dr. Wiseman.
Well, I mean, I think that it's hard to give a counterpoint to basically Jason saying there's not a real answer. And I think the reality is that it's because everybody's different, right? And so I would say that there's not a set rule. I think that patients that come in, if they have pretty significant lumbar stenosis, the most important thing that I'm telling my patients is that their response to an epidural is not predictive of their outcomes for mild. So they may or may not have already seen my spine surgeon partner and had 1, 2, 6, 10 epidurals whose longevity of efficacy like was waning over time. And at that point, I don't think there's any reason for me to come in and say, hey, let me do another epidural just to prove to you that you're going to have a good outcome from a procedure. So realistically, I think it's patient-centric, and it's great to have the data of the fact that, you know, someone might be a good responder to a long-term response from an epidural if they've had with just local only or local with steroid. And up until a few years ago, I think we didn't really have a lot of strong studies that supported epidural use, although we've all been doing them for patients with lumbar stenosis. So the reality is that in the last few years, I think there have been a number of studies from Asia, Korea, showing that there are patients who do well with lumbar epidural steroid injections, whether it's interlaminar or transforaminal, when they have central stenosis or, you know, foraminal stenosis. But realistically, the issue is this: knowing that it's not a predictor of their outcome with mild, I think is the most important thing. So whether the answer is that patients should have 1 or 6 or whatever, at the end of the day, I think when they stop responding to epidurals that someone else is doing, it doesn't help for the provider or physician who's seeing them now to say, well, let me just do 1 more because that person might not have done a good job. The reality is at that point, I think the person who's had epidurals done well and no longer getting efficacy, that's the time to move forward. Now, if someone comes in and their back's pretty messed up and they have pretty significant stenosis, I'm going to also be realistic with them about saying, you know, even something like mild, if you have really severe stenosis, may not be a home run, like they're going to be running a marathon after. But for someone who may not be a candidate for a more invasive procedure, like a wide open surgical procedure that my partner might be doing, it still might be a great option for them. So I think the reality is there's probably not a set answer, but I would say that whether it's 1 or 6, no matter how many epidurals they've had, I don't think that that means that they're going to have a bad response or a great response to mild. And I think that's the main thing that is important, and probably Jason and I could agree with, which is probably going to be a difficult thing for us to counterpoint on.
Wow. So far we don't have a great vote yet because you guys are being too nice and agreeing with each other. So Jason, I'm going to try to shake this up a bit. And then
Yeah,
Dawood
shake it up.
Rebuttal. You know, I had a patient today come into the office, and she's a very intelligent person, and she had been walking every day, and she's very fit for her age. She was about 70, but she looked much younger, and she had a large ligament problem on her MRI, about 4 millimeters, compressing her spine. Great candidate for mild. And we talked about an epidural. You know, the one question is it transforaminal or is it intralaminar? We can debate that. But then, you know, the other thing she said is, why would I go through that? Those don't work in my condition, because she'd done research herself, and she was a PhD before she retired. So do you need to do an epidural at all? Why not? You know, we know for radiculitis it works, but for stenosis, the data is certainly mixed. Do you need to do an epidural at all? And if so, why?
You know, that's a good question. I think when we approach the spine, we have to be mindful that we are performing a procedure. And so the question is an epidural safer inherently than a mild procedure? And when we look at enduring outcomes, and I would say I always will do an epidural injection first, looking at the data, this randomized study that I was describing from 2017. If people are going to get relief, they're going to within the first 6 weeks. So you're not sacrificing a tremendous amount of time doing a 60-second procedure for someone that could give them an enduring outcome. If we do the injection, and again, after the 6-week mark, they're not getting any better, I very quickly moved to a minimally invasive decompressive strategy with the percutaneous decompression, and outcomes are very good, especially with the candidate that you described. And when we think about safety associated with the mild procedure, we're actually posterior to the epidural space. We're debulking a ligament. I still approach it very similarly with other neuroaxial procedures. All that being said, I would typically do a 60-second treatment to see if there is an enduring outcome before I proceed with the mild.
That would you the last question of the session.
Yeah, I think this question is kind of hard to answer, but I was going to ask Jackie. I think you guys both seem to agree that, mild should be done after epidurals stop working. So in your practice, what's the definition of an epidural working or not working?
Well, I mean, let me just say this to that point that Jason just made. I mean, I agree that if something like an epidural would help, but I think the reality is, I look at some of the insurance guidelines, right? So if patients can get a certain number for my Medicare, for example, in my MAC locality, a certain number of epidurals in a certain amount of time, and they're not actually able to get the relief sustained to meet the next benchmark of their insurance coverage, for me, that would be an unsuccessful procedure. But realistically, when we talk about the safety of mild, considering the safety profile of mild from the Midas Encore study demonstrates a similar efficacy to epidural, I mean, I don't necessarily think that patient coming in, Tim, would be someone that'd be like, oh, well, let's just try an epidural first. If they've already done their research and they're ready to move forward, I mean, similarly, if someone comes in and they're interested in a procedure, I think having an educated discussion with that patient and explaining them the risks and benefits, and with a similar risk benefit profile to an epidural, I don't think that offering a patient mild sooner rather than later is something negative. So Dawood, I mean, in a perfect world, I think the reality is we don't have strict guidelines of how much steroid someone should get over the course of a year, and we have more guidelines about how many procedures they can have according to their insurance, and that unfortunately dictates our medical decision making sometimes more often than not. So realistically, I think what % efficacy is a patient going to get from an epidural, not necessarily duration, because like if they only got 40% efficacy for 8 months, is that successful? I don't know, because it's such a unique thing. So I don't think there's a clear benchmark for me. I think 80% relief for 6 months, I would say, is a home run for me, but that might not be enough success for another patient.
Okay, so we're starting to run behind. I just want to, here's what we're voting on. The point's going to be you should do an epidural first, is what Dr. Pope just said. And Dr. Wiseman said you don't necessarily need to. So the point is, you agree with Dr. Pope, you should do an epidural first. Counterpoint, you don't necessarily need to if everything else has been considered. So that's the vote. You have 30 seconds to vote, and we'll see who won that debate. Jackie and Jason, thank you so much for coming on. It's been great having you both. Great job.
You guys.
Thank you.
Let's see what the Jeopardy poll says. What is
We should have the music. How come we don't have the music? There it is.
point to an epidural first has 161.39. So there you go. That's the first debate. Second debate is up now.
All right.
We'll put that up. That's a great picture of you both there, actually.
Yeah.
And now two other great debaters. Dawood, I'll let you introduce the debate.
Yeah, so our next topic, I'm very interested in hearing what these experts are going to say, because peripheral nerve stimulation has really had a tremendous resurgence over the last 3 years. And with that, new platforms and techniques and new indications, but really how we trial these patients, what's kind of the front line. So we're going to have Dr. Scott Pritzloff and Dr. Jennifer Ha talking about the trialing period with patients when we do peripheral nerve stimulation. Should it be a prolonged trial, a 60-day treatment, or should it be a shorter multi-day trial? Scott and Jennifer, the floor is yours.
I think that means I'll go first, Jen. I'll take first knock at it here.
Yeah.
Yeah, so when we're talking about a 60-day percutaneous trial, I think the way I think about this, in full transparency, I implant multiple systems, but I view this kind of as a military vet. I'll call it the SEAL Team 6 or the Stormtrooper of PNS. A lot of these patients that I'm seeing, they're post-surgical and they're solidly still in that acute or subacute phase of pain. And so, believe it or not, I mean, it sometimes can be a hard sell to say we're going to do a brief period of stimulation, say with several days of a trial versus say 2 months worth, and then we're going to take it out, and then we're going to head towards a permanent device. And so this is often a more palatable option to say, hey, look, we're going to see if you're a responder to peripheral neuromodulation, but secondarily, you can get therapy and actually potentially a chance that you're going to get durable relief beyond the period of stimulation. And that durability has been proven. I mean, Dr. Caporal is on coming up, but some of their papers, including Chris Gilmore's paper from 2019, solidly showed durability even with chronic pain in lower extremity amputees. And some of these amputees, I believe the mean time that they had suffered their injury was 8 to 9 years. So it's very clear that even with a 60-day period of stimulation, you could get durability. The second point I was just going to make was I view this as very targeted, essentially the right tool for the right job used in the right way. And so one of the concerns that I have about short trials is that you may have a false negative. And a particular example that comes to mind, we were able to publish this in Neuromodulation, was an upper extremity amputee who we implanted a lead on her radial nerve, and shockingly did not really start to get relief until about the 6-week mark. And her phantom hand that had been clinched for about 20 years cracked open like a clam, which was very compelling, highly unusual. And so the question is, if you're only stimulating for maybe a week or two, you may not have enough time to really get that result that you're looking for. And I tell patients, this is hours in the gym. It's all about getting hours on. I like to see 1,000 hours when patients do a 2-month percutaneous trial. And then the last point, as Dr. Deere comes on, is just really about safety. I think the hardest thing as a neuromodulator, and when you're starting to do PNS, is how close do you have to be? And one of the advantages to a 60-day percutaneous system is really you only need to be about 1 centimeter away from the nerve. And if you're targeting mixed motor sensory nerves, obviously that gives you that added benefit of safety and really being able to stimulate the nerve but not be right on it.
All right, Scott, great points. Jennifer.
Yeah, great point, Scott. I'm going to be kind of talking about the benefits of a multi-day trial, and I'm going to frame it in a mnemonic. So PRIME, precision, response, innovation, miniaturization, and efficacy. In terms of the precision, we all know that a local anesthetic block is not a good prognostic indicator for whether people are going to respond well to PNS. And so it makes sense that we would give patients a trial of the therapy before we're implanting. And one of the major things when we're thinking about a multi-day trial, we're thinking more about the SCS analogy of a 7 to 10 day trial. But with these newer devices, some can be left in even as long as 30 days. So when we narrow the gap to 30 days versus 60 days, is there really going to be added benefit for an additional 30-day treatment? When we talk about durable efficacy of a temporary treatment, we can look again at the spinal cord stimulation literature. You know, if neuromodulation was so effective, then maybe SCS, for example, could only be implanted and used temporarily. But we see that that's not the case, that peripheral sensitization leads to central sensitization, and that we're more likely going to need a longer-term option. And the other thing with multi-day trials is that the technology of the implants that we're anticipating to eventually place in a patient gives us more options, whether that's an 8-contact lead or a 4-contact time lead. One of the other options or advantages, I would say, of a multi-day trial is when there's no evidence base for comparative efficacy of one neuromodulation modality over another, that the patients can have these back to back. So I will have patients who have gone through a PNS trial, also go through a DRG trial, and then an SCS trial. I know it sounds excessive, but when we're thinking about the durable long-term treatment that the patient is going to have in their body for a long period of time, that they would want to trial these options to see which one is going to give them the best chance of success. And when we anticipate a device that is going to be permanently implanted, it's going to open up a number of options in terms of the therapy that we're going to deliver, whether that's layering motor and sensory stimulation. You know, in the long term, we're all pain physicians, so we do want that pain score reduction, but also what else is important? We're thinking about quality of life, functional gains. So perhaps one of the other things that is being explored is perhaps motor stimulation to help with functional gains. And can we really do that in 60 days? I think for some patients to reverse some of the pathology, we're going to need to see some complementary physical therapy as well as the neuromodulation. In terms of the technology, also with the miniaturization of long-term implantable IPGs, we're really thinking that this would be a better solution for patients who are anticipating chronic pain that's going to last beyond just that 60-day window.
Wow, great arguments by both. I'm glad I'm not voting on these. It'd be hard to pick. But Scott, let me ask you the first rebuttal question since you went first, and that is, 60 days. And in transparency, I did both a super scalper 60-day implant this week, and I did a permanent median nerve implant. So I did both things this week alone. So the question for you would be, is there really people who get well over 60 days, and what percentage do you think that is? You have 1 minute.
Yeah, so first of all, when comparing the two, I think there is room for both to coexist, but what I can say is sometimes you don't need a jackhammer to crack open a nut, okay? So sometimes you don't need to go to that permanent device. To answer your question though is, particularly for those patients who are in that subacute and maybe acute window, I continually am amazed at the durability that you get on the back end for those patients. I think what we don't understand is the patients who are solidly chronic, who's going to respond, say, to a 60-day percutaneous trial versus who will, in fact, go on and need a permanent implant. But I would say that if you're really trying to dial in and tailor in the therapy, and this is a great option. The other thing that really goes without saying is we talk about the philosophy of permanent versus temporary, but a lot of times it's really hard to get that buy-in in someone who's had multiple surgeries, perhaps months earlier, to really get that buy-in to say, hey, I want to do this trial that's going to be taken out, maybe a week later, or perhaps up to a month, and then do yet another procedure, a minor surgery to put in a permanent implant.
Okay.
Yeah, great answer. Jennifer, I have a question for you. I think, with this being the periphery, it seems that this would be an unlikely debate if we were talking about spinal cord stimulation. What's your thoughts on the safety of doing peripheral nerve stimulation, extended or short? We've talked a little bit about outcomes. What's safer for patients in your opinion?
Yeah, I think that there, like Scott said, there's room in the sandbox for all of these devices. There's a time and a place for a 60-day trial in that subacute postoperative phase. But when we're talking about patients who may need to repeatedly come back to the operating room for 60-day treatments, I mean, I think the best analogy is, for example, radiofrequency ablation, right? So you get some amount of relief for a couple months and you have patients coming back again and again and again. So it may seem a little bit risky in the immediate term in terms of infections or lead migrations related to a permanent implantation. But the real question is, what's going to be the life course of the chronic pain condition? And if we anticipate that it is someone who's been refractory, likely to continue to have pain, then that risk-benefit ratio kind of tips towards the favor of a multi-day trial leading up to implant. I think it's all about trying to set people up for success and being as precise as possible with our therapy. I'll leave it at that.
Well, I must say, we're not disappointed in the debate. We're going to vote now.
Great
60-day
job, both of you guys.
multi-day
And
trial.
Guy and gal.
You have 30 seconds here. Thank you both so much. You were awesome. That was a great debate.
Thanks,
Tim,
Tim.
Dawood.
Fantastic.
Oh, that was pretty good. Who do you think is going to win?
My vote is for Jennifer. Sorry, Scott.
There you hear it. Dawood's predicting Jennifer with a victory. Let's see how this goes. And Jennifer wins.
All right.
So
I
there
hope I
you go.
didn't I hope I didn't skew the voting by making that comment.
Might have been a little quicker going.
Oh, no worries. I don't have any feelings. It's okay.
Hey, Jennifer, I'll send you the address to send that check. Thank you.
All right.
Okay, our next debate. That was so two great debates. We're catching back on time here. We have Leo and Kieran, Dr. Capro, Dr. Patel. So rescue therapy, high frequency versus DRG. Dawood, any thoughts on this debate?
Yeah, I mean, I think this is something that, you know, when we talk about rescue or salvage, when we talk about patients with implanted devices, how do we kind of rescue them or get their device to start working? How do we upgrade their technology? So I think this is something that's been done, you know, more and more commonly. So today we're going to talk about, you know, rescuing patients with advanced waveforms. Dr. Caparel is going to be on the side of high frequency stimulation, and Dr. Patel is going to be on the side of DRG stimulation.
Leo, you're first.
Thank you. Okay, I have a super smart debater on the other side and very eloquent. So, but I have also good therapy on my side. So let me give you a little bit of, so we have level 1 evidence, overwhelming data in 3 randomized prospective studies on 10 kilohertz high frequency spinal cord stimulation. And those are 24 months follow-ups that substantiates longevity of this therapy. Also, me and my counterpart and partner in crime, Dawood Sayed, came to idea and then published. And this was actually patients' request to look into rescue from the traditional spinal cord stimulation that didn't work anymore. Either that stimulation was not working anymore, or they turned it off for a couple of years, or they just didn't get much of the pain relief. And we published that rescue study about 2 months ago. And if you look at the data, 81% of the patients received more than 50% of the pain relief after they had failure of traditional spinal cord stimulation. Even more, the nice thing about 10 kilohertz, it's a very simple approach as opposed to DRG. You don't have need to replace the system. You have adapters for all of the systems existing there. And then also, if you have a lead crossing the T9 in the middle, you just need to replace the battery and place the adapter, so you don't need to make another incision, which makes all sense and less invasive is to the patients. On the other hand, if you look at the DRG, it's not indicated for back and leg pain, where majority of our patients are when it comes to the rescue from spinal cord stimulation. It's only indicated for mononeuropathy of the lower extremities and the CRPS. So obviously there are certain concerns about safety when it comes to foraminal stenosis and placing the DRG leads there. And then also questionable success rate of this in this patient population. If you look at the Denmark study and some of the issues, Kieran, for example, published a series of those breakages of those small leads when you get to the foraminal opening. Even in that group of patients initially, who were highly selected in the first year of therapy for the DRG treatment of the mononeuropathy, and not those who have advanced spine disease. So my vote is for 10 kilohertz.
Dr. Patel, you're up for your views.
Okay, so those are some great points there. And so, whereas compared to my colleague, Dr. Caporal, dorsal root ganglion therapy is an excellent therapy, but one would say it's one of the newest therapies in our field. And we're continuing to learn more about it. So I implore all of you to apply the best understanding of science and see that the DRG is a new and different neural target. So whereas the mechanism of traditional SCS or dorsal column stimulation is largely GABAergic and glycinergic, the mechanisms of DRG are completely different. They appear to be related to filtration of signals at the T-junction and actually intraspinal inhibition via endogenous opioid receptor recruitment. That's a completely different type of mechanism. So if we are truly trying to salvage a dorsal column system, we need to invoke a different mechanism. Although it is true, our FDA indication for dorsal root ganglion therapy is currently CRPS types 1 and 2, we are working hard, many in this field who have worked with this therapy to establish and to expand this indication. And what we've even seen in a sub-study of the ACCURATE study that was led by Dr. Robert Levy, we found that DRG stimulation was much more stable in terms of pain relief through 12 months as compared to tonic stimulation. We're also finding that we can stimulate the DRG with significantly lower energy requirements. In a recent study done by our group, we see that the inhibitory effect at the DRG can be accomplished at frequencies as low as 4 Hertz without loss of efficacy. This is a fraction of the energy being applied to the spinal cord. And if we take a step back, that seems like the obvious right answer, and honestly has significant implications for IPG Live and certainly obviates the need to charge a device such as with HF10. There is a growing body of knowledge, and in fact, I'm very excited to reference an upcoming paper of Drs. Chapman, Deere, McGillner, and myself looking at salvage of a multitude of systems and waveforms, essentially every manufacturer and waveform on the market. The study follows 62 patients up to 27 months. All of the patients who were trialed proceeded to implant and had either their existing system left in place or explanted following their trial and during their DRG implant. What we found, and some of the studies that Dr. Caporal mentioned, Dr. Ghosh's retrospective study does look at ODI. We found a 34% reduction in ODI when DRG was used as a salvage therapy for a variety of waveforms. This compares to Dr. Ghosh's ODI reduction of 19%. We actually also looked at morphine milliequivalent reduction and finding that the average reduction was from 68 to 40. Again, this is like a very significant reduction. And what I will say about the studies that were mentioned by Dr. Caporal is that in Dr. Caporal's retrospective study looking at HF10 systems salvaging SCS, all of these systems were tonic. And in Dr. Ghosh's retrospective study, all of these systems were tonic as well. However, in both of these studies, all of the previously implanted leads were removed prior to trial with HF10. So first off, one could equate this to essentially a stim holiday or a therapy rotation, stopping tonic and switching to a different therapy. And I think we would all say this almost always produces a happier patient. And again, my second point will be the same thing. For the majority of all patients, pretty much anything is better than tonic stimulation. So from a practical standpoint and from a patient standpoint, if you pretend that you're the patient, if you've committed to having an implantable device and this device has essentially failed you and it's no longer providing you an analgesic benefit, it is significantly more autonomous to trial the patient without committing them to an operation. So what I mean is leave the existing system in place and certainly don't explant it. And don't even open up to connect a different IPG. Just let the therapy declare itself and the patient feel autonomous by placing the DRG leads right alongside the existing system. And I'm sure many of you are out there like, oh, well, DRG is too time consuming or it's too complicated. What I'll tell you is this. be a smart doctor, look at the science, understand it's a different target. And what I'm going to tell you from a technical standpoint is that you need to step your game up and improve your skills and offer the better therapy to your patient. It's a different neural target with an entirely different mechanism. And it doesn't seem to exhibit the same type of habituation that we see with dorsal column stimulation. And that's what I have to say.
Yeah, what a great debate. I think both made wonderful points. Again, I'm glad I'm not voting. But Leo, my question for you is a little bit different. When a high frequency system starts to fail, because this is all about rescue therapy, what are your tips on rescuing a high frequency system? Are there anything you recommend to those doctors out there who may have someone that's not getting an optimal result? Because the data you present is wonderful. The 3 level 1 studies are wonderful. So what do you do if you need to rescue that system? And then I'll give Dawood a question to Dr. Patel.
Yeah, well, let me first make 2 points about the DRG. DRG is mononeuropathy only indicated system, so you don't even get paid if you're covering for back and leg pain. That's the problem. The second thing is the mechanism of action of 10 kilohertz micro stimulation is published in our highest impact factor journal in neuroscience, that's Neuroscience, and documented clearly that recruitment of dorsal horn is the additional mechanism that is not being engaged with any type of other stimulation in a certain manner as it is with 10 kilohertz. DRG we used before we were blocking the DRG 20 years ago and radio frequencies DRG 20 years ago, and we were unable to provide back and leg pain relief because there are so many inputs. Sympathetic, those pain fibers that go along the sympathetics back to the spinal cord and the brain, they're just positioned at different levels, anywhere from L2, 1, T12, and so on. So really, just stimulating 1 or 2 levels, you would need to stimulate in somebody with a failed back 4, 5, 6, 7 levels. The danger of this is that the safety is going to go down as we go to more of these levels placed in the leads. To answer your question about yes, we have the opportunity to combine different waveforms. Just to answer your question quick, we had a opportunity to combine with the new Omnia system with the 10 kilohertz, that we can combine various type of other stimulating patterns, including the burst and including the low frequency type of stimulation. And it seems that in a very few patients that we were going to it, we were able to achieve decent relief of the pain. So yes, I did try. I tried in 3 patients up to now, and it worked pretty good. So yes, you really need to go to those therapies that provide high level of response as opposed to traditional low frequency type of stimulation.
Very good, Dawood.
So Karen, who is the ideal patient to rescue with DRG? Because when I think about in my practice, and I always give Leo the edge if he quotes a study, I'm in with him too, but it's usually patients, would fail to get good coverage of their back pain. So how would you rescue that patient with DRG?
So I will definitely answer that question, but let me get back to the question about the science, about the concept that you would need to stimulate multiple levels in order to stimulate the back. So actually what we are learning is that, the spinal nerve at T12 is actually responsible for the soft tissue and the skin. And so what we see is that when it ascends in Lesueur's tract, it basically essentially goes to the convergence point of T89, which is where the spinal fibers are going for all of our spinal levels. And so when we have that enhanced inhibitory effect at T12, that is then landing on that convergence point.
That's only discogenic source, and this was 20 years ago by Ted Klein.
Give Dr. Patel 30 more seconds. We're actually running out of time. I know you asked. So Dr. Patel, you have the floor.
Let's give Dr. the voting.
I was just muted.
Go ahead, Kieran. 30 more seconds.
So what I do want to say is this: to answer your question, Dawood, who is the ideal candidate? It is your typical post-laminectomy patient, and I'm going to say that because we can say that here. Not having accurate, not having good back coverage, not having good leg coverage, throw in a T12, put in an S1. That is honestly, that everybody has a patient like that in their practice. And what I'll say is that, you know, this is a different mechanism because it's a different neural target. And that we have to think about that and understand that.
All right, Dr. Patel, Dr. Capral, amazing job. That was a great debate. I really loved it. We're going to vote now. Everyone's got about 30 seconds to vote. Dawood, who do you think won that debate?
I mean, that pretty much brought back Trump versus Biden debate number one. I mean, it was ferocious. They were both frothy. I think I'm gonna have to give Kieran the edge just based on her ferocity there. Leo was like more like Sleepy Joe there. Sorry.
You mentioned a couple of my studies, so
Did you just call me Trump?
You won. Here we go. Oh, Leo.
Wow, it was tight. It was a tight one. Leo with the edge.
Sorry, Dawood, you lost.
Hey, Kieran, I think Doc reached you. I think that's what happened. So
that just means we have to educate more people. That's all that means. That's all that means.
Thank you both so much.
Great job, guys. That was phenomenal.
Our next debate is coming up now. We have Dr. Mehta and Dr. Fishman. Dawood, you want to introduce the debate?
Yes. So you guys got a lot to live up to after that last one. That one, the gloves came off there for sure. So hopefully you guys can keep in that same spirit. So today we're going to talk on this next debate about what is remote care versus remote monitoring. We've all seen kind of some of the recent news with the ability to potentially program our patients remotely with some of the new platforms out there. So we're going to have Dr. Pankaj Mehta start, and then he's also going to be debated with Dr. Michael Fishman. Pankaj, you start, please.
Oh, thank you, Dawood. Mike, great haircut, by the way. Haven't seen you in this for a long time. So good evening, everybody. You know, I don't know if this is really a debate. I mean, remote care and remote monitoring is pretty much the same thing. And me and Mike probably have pretty much the same practices, but you know, I'll start off by saying that one of the things we learned during COVID was that, you know, you couldn't get out and you had to stay home and you couldn't really offer that face-to-face care of healthcare, no matter how much we enjoy talking to patients and kind of like, you know, dissecting their diagnosis down and triaging their pain generators. And so we learned that, you know, there are a lot of things have to be done to maintain something remotely. Now, what does that really mean in neuromodulation, right? We're all neuromodulators. Mike's a researcher and a neuromodulating researcher, and I run a lot of studies in neuromonitoring. Neuromodulation. So what does it really mean for us? You know, we have to understand this concept of the SCS ecosystem. And as neuromodulators, all of us who are on the debate today, on the call today, we all strive and work very hard to develop a healthy SCS ecosystem. And the terminology, the SCS healthy SCS ecosystem means it basically offer SCS therapy timely to the patients who are struggling with opioids, who are in the community, who are because of lack of knowledge. So that's the first part. The second part is when they're carefully selected by doing proper education remotely to the peers and getting those patients to timely help, then and you offer them or you basically put in a spinal cord stimulator, how do you then monitor that test drive, that trial period, so you can make sure that the internet myth doesn't take over, right? Number two, that's the best therapy you've selected for the patient. And number three, that during the course of the test drive or the trial, you're monitoring that patient, providing that care, and that's why I said monitoring and care to me are pretty much the same thing, so that that patient then understands the importance of that therapy for their chronic pain syndrome. We all know that 5 days, 7 days, 3 days, whatever we do is not enough, right? We've also heard things like, oh, my trial helped and my implant did not help. We hear all those things when we are taking care of those patients. So what can we do when we are sitting, taking care of other patients, but still having our third eye, that big brother eye open on these patients and watching their functionality, watching how they're doing with their pain. And then comes the real part, right? So what is that real world scenario? So you've selected these patients carefully, you've educated the community, you have selected these patients, you've offered them the correct therapy, and then now the patient gets an implant. That's when the real journey starts. I remember talking to all of us on the call during different conferences that it's not about, oh, I did a great stimulator, or this is a great picture. It is about the maintenance therapy or monitoring a neuromodulation therapy when the patient has had an implant. Same thing was endocrinologists do when they put a diabetic implant in or an insulin implant. The game starts when you actually have the SCS implant in. How can we achieve this during the midst of complex logistics in our office? How can we achieve that with numerous SCS reps? Sometimes they're different reps, different companies we do in our practices. And then how do we then measure those functionality measures and outcomes during the course of the journey during an implant so that we can timely identify a failure, right? So one of the things we do is we're good at troubleshooting. I feel all interventional pain management neuromodulators are excellent in, or have been taught and trained in, troubleshooting. And the only way you can do that is if while taking care of other patients, or while sitting at home, or while sitting in your clinic, you can keep a third eye on these patients who are there. So 3 different phases. And so I believe that the terminology is care for all these 3, but if you dissect these down into individual components, the pre, the intra, and the post, you're actually monitoring them. And so to me, I think this is a joint hands with Mike on this to actually offer both excellent monitoring in each of these subsets, eventually leading to excellent remote care while sitting far away from the patients. Tim.
Pankaj, I love you. That was such a sweet debate. It was touching my heart. Michael?
Well, I mean, first, I think, Pankaj, I appreciate the illustration that you've provided to us about care and monitoring, because I did not think there would be a debate, because you're right, we agree in many respects on a lot of the things that you said. But actually monitoring or care are completely different entities. And that's one of the things that I think is very important, because remote care, I actually would advocate in pain today, is emerging very nicely. And there's been quite a bit of tailwinds moving that forward. Of course, pandemic has been a significant tailwind to that. But the concept of patient habit and physician habit is a critical component to moving care virtually. However, monitoring has incredible potential to impact lives, remote care, and a whole host of different things. But in pain, I actually don't think monitoring is nearly as robust as it needs to be for it to be impactful. And I don't think remote care from that point is that good to be impactful either. For example, there's a lot that you glean from physical examination. Now, on the flip side, remote care that is nuanced and informed by data, that's actionable, that measures objective measures that may be foundational to individuals, that is, we may be looking at a trend, or foundational to populations. And right now, we just don't have that robustly in order to be able to make the types of remote care decisions that would bring us to the next level. Let's take an example. Right now, Boston Scientific has a device for heart failure that can predict a heart failure event weeks in advance. Teva has a connected inhaler, and Spire Health has a connected inhaler that actually looks at patterns of spirometry and inhaler use and can predict asthma attacks. We have just emerged from Crayola smiley faces to start appreciating the complex biopsychosocial construct that pain is. So our surrogate measures are not robust enough for remote patient monitoring. One of the big challenges now is going to be asynchronous data captures, building the models that help us understand how to make these predictions and how to do that. But that still requires inputs, because our inputs are fairly poor. So I believe through a combination of things like remote care, things like virtual check-ins that may or may not lead to a in-person visit to close the loop on patient care. I think that some advancements with our industry partners towards remote programming will improve convenience for patients and improve aspects of care. But remote care, for example, troubleshooting one of your patients who has a spinal cord stimulator and recurrent pain, it's a lot harder to do without examining them. So I appreciate where we are, and I look forward to where we're going. but I guess I do disagree with you, even though I agree with most of your points.
So Michael, great job. And again, last debate, we got a little heated in this part. It's 1 minute each. And I'm going to ask Pankaj the first question, and then Dal will ask Michael a question. So Pankaj, I saw your post on social media. You did remote programming last week of a patient who was at home, as did I. And I think, it's really kind of, for my patient, it was kind of an amazing thing because they had trouble traveling at all in a car because of their condition, medical condition. So what do you think that's going to do to therapy in the future, the remote care, remote programming of devices?
Yeah, so Tim, just kind of like piggybacking on what Mike said is that it's no therapy is for everybody, no modality. Evolution never benefits everybody, but evolution benefits a lot of people, and people then build on that evolution to then decide the next step of changes. So, if you have a practice, like I have a practice kind of like yours, which have a catchment area far away. So that particular patient, the first one, it was a DRG, actually a DRG salvage on a large paddle put in a thoracic area. And like Kieran had said in the last debate, like something like L1, S2. So you're on the edge, right? You've already failed the therapy before. And maybe the therapy was not the right therapy for that patient, and now you're sitting far away. It's a 6 days or 7 day trial, trying to kind of figure out this is your last resort. And I think I did meet you a couple of weeks back where I showed you the graphs. You can monitor that. You can provide that care remotely for this patient and make sure that you're achieving the same thing. That's exactly what happened. You were able to step by step plot a graph and spit out a graph showing that the patient is benefiting from that rescue therapy of that was a DRG, and then the patient starts believing in that therapy when they look at that and said, okay, well, hang on, I actually was at a flat baseline, but I'm actually having a steep improvement in functionality or PROMIS 29 squares and 29 scores and everything else. So I think it has a real value in a lot of practices. But again, like I said, evolution is not for every practice.
Very nice, Dalwood.
Michael, we kind of look at a lot of this from our lens as a physician. What do you think the patient's perspective on this whole debate would be?
That's a really good point. And one of the things that I think we all need to keep in mind as we are approached in various settings by people who want you to monitor people's blood pressure at home as a pain physician is recognizing that the clinical utility of what you are doing has to be actionable for you. The segment adoption, that is, the patient and the physician have to engage in whatever strategy you're going to choose, whether it's capturing outcomes or whether it's capturing more robust types of measurements that people are moving towards. The big challenge that we have to understand is returning value to our patients, because we know that people don't want to just take tests, except for doctors. People don't want to just be treated as a number. They want insight into their condition, their journey of care. And I believe that remote care integrated with actionable patient monitoring that's germane to that patient's scenario will survive. I think asynchronous data capture is here to stay, but I do believe that there will be nuances, and those nuances will be people reviewing explanations of benefits and wondering what the value they're getting from a service that you've provided to them on a CPT code. So I think that reimbursement, the business model, is probably going to shift as our documentation needs a shift, and also as the focus on real-world evidence by the FDA and by the device companies, and also mostly drug companies, becomes so important that it helps us understand in the real world how to select therapies and create patient therapy fit. That's when we create value. That's when taking the test makes sense. But right now, like I said, we're in data capture mode. We're not diabetes, we're not heart disease, and we're not chronic obstructive pulmonary disease.
Great points, Michael. Pankaj, Michael, we're going to have a vote now. Dalwood, who do you think won this debate, for remote care or remote programming? Which more important? They both are very important, I agree, but which is more important?
I'm going to abstain from voting here. I feel like I'm skewing it, so I'm just going to stay silent.
That's, you know, so every other one it was a politician, and this one it's apolitical. I like that, Dawood. Switzerland.
That's right. I'm scared of both of these guys, so I'm just going to stay quiet.
I just think Dawood has not really moved into the computer age yet, so he's not quite sure what things mean.
I was so confused during that whole thing.
No, he knows what pro means.
That's right.
Here we go.
Oh,
So-
there it was. Pro monitor.
About 10%. So there you go. Good job, gentlemen. Thank you so much.
Cheers.
We'll go
Thank
to-
you.
Guys, have a good night. Thank you very much. That was
The
excellent.
final four. These debates were chosen to be maybe a little bit longer, a few minutes extra per debater as we had the final four here. Two of our dear friends. Dawood, would you like to introduce our debaters?
Yeah, absolutely. So I think this is, again, a really hot topic right now in our space. You know, our field, you know, and I kind of look at this very glowingly, has evolved rather significantly over the last, you know, maybe just 24 months, really, to be honest with you, as we voyage into intervening with minimally invasive spinal procedures. And this was kind of brought to the forefront with the Superion or the Vertiflex procedure that was, you know, has been done fairly commonly now. I could say it's almost kind of a bread and butter procedure for a lot of us as interventionalists. But we're also starting to see of late is moving beyond potentially just, you know, spacing the area, but using these interspinous spacers to fuse a segment. So using spinous fusion clamps. So what we're going to talk about and have a pretty robust and healthy debate today from Dr. Jonathan Carlson, who's going to be pro interspinous spacers from Hawaii, and Dr. Ajay Antony, who's going to be pro spinous process fusion clamps. Jonathan, would you please start?
Yeah, so I think for me, and aloha to everybody, I'm just honored now to be here. For me, I don't know if this is debate just yet, because I feel like we're kind of mixing apples and oranges. I get the heart behind this, but I feel that an interspinous fixation device is fusion and a Vertiflex is motion preservation, or it limits extension. And we're talking about patient selections. I'm hearing a lot of colleagues around the country say, well, I put in a bunch of Vertiflex and they're failing. And I'm not trying to say that my colleagues aren't astute and aren't able to do these procedures properly and select the proper patients. But as if anything in our specialty, unfortunately, some people push the indication, some people are doing things off-label. No, don't get me wrong, it's okay to do things off-label. 80% of drugs in pediatric hospitals are off-label, so I'm told my pediatric colleagues. So, and of course, steroids, and we do epidural steroid injections, are off-label. So I'm not saying that that's bad, but I mean, just look at the CPT codes for this. We're using posterior fusion codes. We're using arthrodesis. There's a graft going in. I think this is more of a definitive thing. And so I think the mistake that's being made is that interspinous fixation devices are replacement for Vertiflex. And I just, at least right now, based on the evidence, I can't agree with that. I think maybe if you're trying to unpack that why we're having failures with Vertiflex, I would surmise that it's because we're having pushing of the indications. I mean, we have really great data. I would consider it level 1 data. It's published in Spine, a 2-year study. It was 190 patients times RCT, multi-center, 29 locations, 190 in the Vertiflex side, 201 on the X-stop side. And in essence, a really good study, carried over 60 months. I mean, what study do we have in pain management? I mean, you can argue even in spine and neurosurgery or ortho spine that goes out 60 months and has sustainability. After 60 months, there were 66% of these patients reported a great relief, 66% relief with low back pain, 75% relief for leg pain, 85% reduction in opioids from their baseline when they started out 5 years earlier. And the big one, 90% satisfaction rate after 60 months of having this device implanted. I should also mention 2-year data showed that there's a 15% reduction in ODI in 65% of these patients. So these are, in my opinion, huge numbers. And you can't take away that this is great data. And there's multiple studies. There's about 15 different studies that are showing that this is sustainable. And then we have the press registry. So let's just translate that into real world data. Dawood, Saeed, and other colleagues were involved with this. And it showed that of 2,000 patients, 86 sites, that we had leg pain at 72% relief, low back pain at 67% relief, and a little bit lower with patient satisfaction, but still very high, 80% relief. So I think what's going on here, in my opinion, I think there is a place for patient selection. I guess I'm kind of going the pro side, but there is a place for this procedure with the interspinous fixation device. I think would be maybe in a case where there's maybe a spondy that has a little bit of translation or subluxation going on, grade 1, grade 2, but it has to be the properly selected patient, in my opinion. I think the reason why we had failures with Vertiflex is perhaps they were being put in patients off-label and severe lumbar spinal stenosis, although I have to admit some of my best successes were in patients like that. And then I think that maybe, and I don't mean to cannibalize things for Vertiflex, and this needs to be studied, but I kind of wonder some of these failures were done in patients that actually had maybe small grade 1 subluxation, 1, 2, 3 millimeters. I know some would argue 3 millimeters is physiologic, but let's just say it's not. There's a movement with flexion extension. Maybe those patients should be getting a Vertiflex. Maybe they should be getting an interspinous fixation device. But I think bottom line, and this is really kind of the punch in the end here, is, or the 3-point shot at the end of the buzzer, is that right now we don't have really any good data for interspinous fixation devices. I mean, level 3 at best, retrospective. So if I really to be intellectually honest, I have to follow the data, and that's why I would pick Vertiflex for motion preservation for mild to moderate, sometimes maybe the properly selected patient for severe lumbar spinal stenosis. And if that didn't work, then, or if there were maybe some subluxation, then that's when I would consider interspinous fixation device.
Jonathan, right on time. Great points. Jay, you're up, my friend.
Oh, great job, and thank you for having me on here. And it's an honor to do this with my brother, Dr. Carlson. I certainly will also mention, he didn't take the opportunity to do so, but I will mention that this is not the first time that a Florida Gator has met an Oral Roberts Golden Eagle, and it didn't work out for me so well last time. So big props on that one. I do want to take a step back and just kind of reiterate where we are as a field. So, you know, over the past 2 to 3 years, we've seen a dramatic shift in where we are as interventional pain physicians and in our field. We moved away from solely treating symptoms and moved to sometimes the definitive treatment for mechanical issues. We've seen that certainly in the SI joint space of late. We've seen that in the spinal stenosis space with you know, robust evidence, as you mentioned, for extension blocking devices like the interspinous spacer. We've also heard about mild procedure for direct decompression of ligamentum flavum. And I think that this is the next opportunity for us to examine whether this is an appropriate therapy in our hands. And I think that there is some argument to be made that it needs to be investigated further in a very positive way. I do want to kind of move away myself from the term of spinous process clamp, because it's really important that we understand what we're actually doing here. And we're using this as a fixation or fusion device. And so I completely agree with Dr. Carlson that the conversation is not so much interspinous spacer versus versus kind of a spinous process clamp or fixation device, but really we should be talking about a fixation device versus a pedicle screw. And that's actually what's been looked at before. These patients do exist in our practice. As Dr. Carlson mentioned, the Punjabi and White study shows that, you know, greater than 3 millimeters of translation between flexion and extension of the vertebral body does define a pathologic in terms of hypermobility. And the indication for a posterior fixation device or posterior fusion device between the spinous processes is not spinal stenosis. It's degenerative disc disease, it's trauma, it's spondylolisthesis, and spinal stenosis is being studied for this indication actually in Europe, directly compared versus laminectomy, and favorable results early on with decreased blood loss, decreased skin-to-skin time, but that evidence is still evolving. We do have cadaveric evidence for spinous process fixation devices using the lateral approach that shows, very, very good distraction of the foramen when done in combination with the lateral intrabody fusion as well as done alone. What we need to evolve is the evidence for the use of a posterior fixation device between the spinous process without the adjunct of a lateral intrabody fusion. And that's how it's been used historically. I think we need to figure out whether or not the, fixating the 30% load of the posterior elements is enough to overcome the anterior load, which is, housed by the vertebral body and often accomplished with the lateral fusion by a spine surgeon historically. We do also need to define the term standalone use, because I think that's a very important concept here when we talk about posterior fixation devices. Again, historically, it's been used in conjunction with a TLIF or lateral interbody fusion by a spine surgeon, in which the spine surgeon is using a spinous process fixation device in conjunction with an anterior or lateral fusion using a biologic, and that's bony matrix. What we're trying to find out here is whether or not the use of that biologic in between the posterior elements in terms of the spinous process and lamina is going to produce a similar result. And that's the question that has not been determined as of now. I do agree with Dr. Carlson that, you know, this is a different patient, and these patients do exist in our practice. We all had patients who we've talked about repeat epidural steroid injections. We've talked about that patient in our practice who has a combination of mechanical and neuropathic pain that has a degree of instability that, you know, may not be a good candidate for a spine surgeon. And so I think there is a place for these therapies in our practice, and a place for us as a field who, as interventional pain physicians, we are best equipped to perform these minimally invasive fluoroscopic guided procedures to investigate that further with high-level evidence. I definitely think that the conversation needs to move more towards, you know, comparison to an open surgical decompression instead of indirect decompression for spinal stenosis. So we need to be talking about these in comparison to pedicle screws and open surgical fusion instead of spinous process, you know, extension blocker. But I definitely appreciate the move of our field to investigate what we can do in our hands for our patients.
So great job, Ajay. Very nice. John, question for you. You know, we were involved in the 5-year study. We were the only non-surgeons involved. And in fact, there was some criticism that maybe non-surgeons shouldn't do this. And now, as you know, we're the ones doing this. And you know, it was a great innovation for us. So I guess my question for you is, for interspinous spacers, what's the next innovation? Is there room to make the procedure better? Can we do something differently there in the future, do you think? What do you think the future of interspinous spacers might be?
I think it stands strong based on the evidence. I kind of already alluded to this earlier. I think I'd like to see a study to look at the failures of the Vertiflex, if people would be brave enough to admit it. And I kind of wonder if, like I'd mentioned earlier, were they a grade 1 with little subluxation? I don't have to cannibalize those patients, but maybe they shouldn't be done. And that's why there are some guys that were really huge utilizers of Vertiflex going, I had heard, to using the interspinous fixation devices, but maybe we need to look closer at, okay, should we be doing this even if there's a little bit of movement in these grade 1 spondylolisthesis patients, even, you know, oh, it's 3, it's 4, it's 2 millimeters, but maybe we shouldn't be touching those patients. I'd like to see that studied. So I think maybe scaling back a little bit is where I look at this in the context of those patients. But I think, you know, in the patients mild to moderate stenosis, 1 or 2 levels as a standalone with FDA approval. Unfortunately, the interspinous spacers, interspinous fixation devices, my understanding is have clearance, not as a standalone, to Ajay's point. I think the future is bright.
Very good. So it's like patient selection is where you would focus, Dalwood?
Yeah, so I think in the interspinous spacer, you know, there's really only one, you know, after X-Stop got taken, really one FDA approved device. But in the spinous process fusion clamp, or whatever we want to call it, that market is a little bit more crowded, Jay. And, you know, we have, you know, they all started from the ASPN predicate device, and all these other ones kind of followed. How do you kind of, when you look at these, how do you differentiate these? What is the difference? Is it about kind of, one is it from the approach, or is there something about the way they clamp onto the spinous process? How do you kind of make sense of, kind of which one to use if you were going to use one?
I think it's important that we kind of look at what we're talking about. So just to kind of make one point about Dr. Carlson's point is the definition of standalone use is whether or not we're using the biologic, the bony fusion. Where we put that is kind of the question here. In this case, it's put between the posterior elements to fuse between the spinous process. When talking about the approach, I think we need to think about invasiveness and tissue sparing capabilities. And so there are basically two approaches to this problem. One is going to be a posterior approach, and that can be done in several different forms. In those cases, you are not sparing ligamentous structures that are thought to be involved in stabilizing the spine. And one of the big advantages from the extension blocking mechanism that Dr. Carlson's talking about is you are sparing those tissues with a vertical incisional approach, sparing the ligaments. The lateral approach is tissue sparing. I think that's the key differentiator right now in the posterior fixation device world. But again, the evidence for both efficacy and, most importantly, in our hands, safety needs to evolve.
Great answers for both. We'll go to the vote now. I think ASPN has a goal of advancing minimally invasive procedures for interventionalists in a safe and efficacious manner. So I think you both made great arguments about efficacy, safety, and again, at the end of the day, the way that these procedures win is by improving the data, improving the safety profile, and certainly it's much safer than larger procedures in most cases. So great job by both. Who do you think won this, Dawood?
Well, again, I always get the tough part of the debate. I think that was really tight. I think Jonathan Carlson, I'm going to give him the edge. He had a little bit. It was stacked in his favor just a bit. He had more data to support his cause. So I think I'm going to give Jonathan the edge.
Much like Oral Roberts, just whooped out of Florida on the basketball court. Today it happened again. Jeez, good debate, gentlemen. Thank you so much.
Great job, guys.
Hopefully. Take care. Thank you. Our next debate, and I think is this. I think it may be our last debate. Is this our last debate? I'm not quite sure.
Well, this is it. The main event.
So we have, I think, a very interesting discussion on waveform versus platform. So Dawood, I'll have you introduce the debaters.
Yeah, our final debate. It's the last debate of the final four. Will be about clinical decision making, waveform versus platform. We've had a lot of really great and exciting innovations in our field over the last few years that have dealt with waveforms. But when I was doing my fellowship 10 years ago, it was really all about the platform. This battery kind of charges faster, and it's got these types of features. But now we're kind of trying to circle back to that again. And there's some things, sometimes we get an advancement in the waveform and the platform. So we're going to have Dr. Weiderholtz talk pro waveform. And Dr. Josephson take the viewpoint of pro platform. Matthias, would you please start?
All right. Thanks for having me. I'm new to the group, so I wanted to thank ASPN and the organizers for including me. Thanks to everyone at home who's watching, and particularly thanks Dr. Josephson for going toe to toe with me on this fantastic topic. And I've been very interested in the other debates that have been going on tonight, so kudos. These have been really fantastic debates. I'm arguing the pro waveform side, so let's dive in on that. So as you all know, tonic stimulation has essentially been the standard in neuromodulation for decades. And while there certainly have been advancements in neuromodulation platforms over the years, the true essence of what we do and why we do it comes down to science. And science equals waveform. I think we can all agree that RCTs, or randomized controlled trials, are considered the gold standard when performing a study in our field to look at any intervention that we do. Most RCTs that have been performed in the last decade have all studied various new waveforms and their ability to outperform the gold standard, which is tonic stimulation. While platforms have essentially remained unchanged, leads hooked up to batteries, waveforms have essentially advanced exponentially in that same time. We now have various new waveforms delivering sub-threshold stimulation, and we have RCTs to prove the efficacy of these waveforms at reducing both back and leg pain. Burst, HF10, combo therapy, DTM, and closed loop stimulation. These are all major breakthroughs in neuromodulation, and they've shown statistically significant benefit over tonic stimulation in RCTs. Take the most recent RCT on DTM stimulation. Rooted in basic science, applied clinically, they achieved an 84% responder rate for back pain. And 7 out of 10 of those patients were profound responders, meaning 80% or more reduction in back pain. In 2017, we had the Sunburst and Accurate trials, which proved efficacy of a sub-threshold stimulation using the Burst DR waveform for both dorsal column and DRG stimulation. And in 2015, you had the Senza study, where you had 12-month data published showing superior efficacy of a novel waveform using 10,000 hertz at a specific target, namely the T910 interspace. And they found an over 80% responder rate for back and leg pain compared to roughly 50% for tonic stimulation. And that was sustained out to 12 months. And then the 24-month data was published and showed superiority of HF10 with about a 76% responder rate. You sense a theme here? All companies rigorously studying therapy success. But what's being studied? It's not the platform. It's unique waveforms and how they're being implemented to achieve pain relief. What's critical to me as an interventional pain physician, and I'm sure all of you out there as well, is patient outcomes. While a platform certainly is important, its main objective is simply to deliver the therapy, the waveform, to the patient to achieve the desired outcome, sustained pain relief. Battery size, longevity, MRI conditional status, lead array, and now even remote programming, these are all important, but none of them determine patient success. Patient success is determined by the very therapy that's providing that pain relief, and that's a waveform that's been studied and proven in RCTs. So in summary, the platform is essentially nothing without a proper waveform stimulating the correct target in order to achieve pain relief and therapy success. Thanks.
Very nicely done, Matt. I think your overview of the studies were quite nice. Joe, you have your hands cut up for you.
I do, yeah. So I thank you, Matt, for setting me up here. And I would absolutely agree that as a fellow coming out of training where we only had tonic stimulation, I was a huge believer in neuromodulation. The things and the studies that have occurred and have brought us up to date today were tremendous advancements and huge impacts on my career and all of our careers, and have made tremendous impacts on our ability to provide the best care for our patients. But that does not change the fact that a tremendous number of these stimulators that are implanted get explanted. There is an overwhelming number of patients who present 6 months, 1 year later, who say, "Doc, this is not the same treatment that I had when I had my trial." There is not a single one of us who can say that in our clinical experience that we have not experienced the same type of thing. Now, while waveforms are tremendously important, while it is important that the DTM study provided 84% responder rate at 12 months, that was superior to conventional therapy, that while HF10 proved to be superior, and DRG stimulation is what it is, there is no arguing the fact that explants occur, and they occur at a very high rate. So having the platform to be able to manage these patients is extremely important. And having a one-sided view that patients only are going to benefit from one waveform is proven to be detrimental. When we look at patients and their reasons for explantation, we come up to a couple of different factors: whether the system is discharged or overcharged, system explantation, and then whether the patient is just not using the system at all. When we look at whether the system is discharged itself, we talk about patients who simply have issues with their batteries, whether the battery itself is a non-rechargeable battery, whether or not the patient is utilizing the battery or charging it, over discharge occurs, and the patient simply has or the battery itself flips. Anytime a patient has issues with utilizing the system in and of itself, it is going to lead to patient dissatisfaction, and that is going to lead to patient's explantation. When we look at MRI compatibility, it is in the real world that 82% of patients will require an MRI within 5 years of implantation. The requirement for an MRI is vitally important. I know all of us in our practices have had situations where we have had patients who have required their systems to be removed to be able to undergo an MRI. Now, again, I utilize the Medtronic system with the SureScan technology, which again allows us to utilize MRIs in these patients, and whether or not impedances are an issue or there's lead fractures, the MRIs are always okay. Another primary issue is, and again, Dr. Mehta, I always quote him in that, no matter, he always says that no matter where you implant the battery, no matter what, the patient is always going to have discomfort at the pocket site. Pocket issues are a major cause of explantation as well. So utilizing a battery that allows for you to implant the system deeper is going to be a benefit to that patient as well. And then the other issue is that, you know, these systems do not live in a vacuum. Patients move, patients change positions. And when those patients change positions, they can end up having increases in their stimulation, ramping, which can lead to discomfort or other issues. So again, things like adaptive stimulation, which has come forward, has led to patients having the ability to have their system be smart enough to be able to adjust to positions. And then, you know, closed loop therapy is its own animal, and we're going to see that, you know, closed loop therapy in and of itself is going to lead to better outcomes as well. So I think that just looking at a waveform, as the waveforms are tremendously important, just utilizing the waveform as a reason to implant a patient and forgetting the fact that all of those platform measures are extremely important is going to potentially lead the patients down to a one-sided therapy and may lead to explantation in the future.
Wow, that was a great debate. I think you both made wonderful points. Matt, I'm going to ask you the first question. You both have. Let's take the vote down. I'm going to chat.
Yeah, it was a little early on that.
Yeah. Here's the question for you. The question is this. You know, I think there's an opportunity sometimes to tie both the platform and the waveform. I'm currently working on 2 waveforms in a confidential fashion, very early. They haven't been put in humans yet. Where do you think we are in the waveform search? Are we early in the game still? Is there a lot of waveforms we yet to discover, or you think we're pretty mature in that field? Matt, that's questions for you.
Yep, sorry, I was muted. It's my opinion that we're still in the very early phases. If you look at just the entire scope of neuromodulation, we really haven't seen novel waveforms until maybe the last decade or so. So everything was pretty much tonic stimulation until about 8-10 years ago. And look at what we found in the last 10 years. We've seen just this massive uptick in new waveforms being developed. And that, in my opinion, has really been the game changer as far as the success of therapy. Let's look at even, you had an earlier debate about salvage therapy. What is it that's salvaging these devices? It's a different waveform. It's not a platform. So we're looking at various waveforms and how they interact with that patient. And probably what we ought to be looking at, and maybe we won't see this because of device manufacturer competition, but you need platforms that deliver every possible waveform combination so that patients can benefit from all of these different therapies.
Yeah, I don't think we'll ever see that where they're actually the true other waveform imitations of that. But that's a great point. I wish we'd see that. That would be a great thing. Dawood, your question?
Yeah, so I think we kind of know that, you know, with the waveforms, we know where the opportunities lie. Better efficacy, better longevity effect. Joe, what do you think are the biggest opportunities for improvements in platforms?
So I think that, you know, I think Matt in his discussion about the importance of waveforms, I think waveforms are absolutely important. They're absolutely, I think I would, you know, just to comment on Tim's question, I think we're at the tip of what we're going to see in terms of waveform development. There are so many different targets that are going to be developed as new and novel waveforms occur. However, without a platform that is able to deliver the energy, the ability to drive the engine, you know, you can have the fastest, most sleek car in the world, the most aerodynamic system, but without the engine that's going to be able to develop and to be able to drive that engine, there is literally no way to deliver and to provide a patient satisfactory experience. I mean, if you look at Nevro with HF10, I mean, the charging burden on patients was tremendous, and their need to charge every day. And even when you look even further at the fact that even the Omnia battery now allows for switching between waveforms, we're seeing more and more that the platform also, you know, aside from the waveform, again, I'm not taking away from the fact that the waveform is important, but the ability to not put every patient into a one-size-fits-all category, to allow for that versatility to be able to switch from platform waveform to waveform is going to be vitally important. And that is what I think is going to be what the salvage therapy is. Salvage therapy is going to literally be the ability to shift from one thing to another without having to pigeonhole one patient into one type of therapy.
Great points by both of you. Well, we're going to the vote now.
Good
Certainly,
job, guys.
you both made great points, and the winner is
Nope. Pro Waveform.
Good job, Matt.
Joe. It was a great.
We tried.
I don't think your rebuttal got put in there, so you might have got some points there because I thought your rebuttal was quite excellent.
I love you, Matt.
Yeah.
Thank you both very much.
Guys.
A few announcements before we close. We're going to be live in Miami with proper precautions for anyone yet who's worried about COVID. Most of us have been vaccinated, I think, by then, hopefully, but we're going to be able to properly space and all that, but we're going to be live for sure. We have certainly reserved enough space that will be in a good position. So July 22nd through the 25th, the full agenda is actually going to be coming on our website very soon, Dawood. I think you've worked with the committee to finish that up recently, and invitation to faculty very shortly. So hope to see all of you there. And I think it'll be the biggest and most exciting meeting we've ever had because we've all been cooped up in these rooms for the last year. So Dawood, other thoughts?
Yeah, hopefully, I think it's going to be, I think we're all really excited for the annual meeting in Miami in July, and hopefully won't take a page out of the spring breakers from last week and cause some riots or anything like that. But I guess my final question is the Final Four. Your Mountaineers are not in it. My Jayhawks aren't in it. We have Baylor versus Houston on one side and Gonzaga and the Bruins on the other side. Who you got? Who's cutting down the nets?
So once West Virginia is out, I really, my stomach is bad and my heart's not in it. So really it's hard for me, but the coach of Gonzaga is good friends with my main man, Bobby Huggins at West Virginia. So I'm gonna have to go with Gonzaga on that one.
Yeah, I'm with you. I think it's the Zags year to cut down the nets.
So there we have it. But you predicted wrong all night, so I'm not sure your predictions.
It might be it might be Houston. Who knows?
Everyone have a great night. We'll see you again with some young guns in May, where we'll have about 30 young people who are again future leaders debating topics that we'll have yet to choose. So that'll be coming soon.
Yeah, thanks everyone. Thanks for tuning in. We'll see you next time.